So this award was created by the program planning committee to recognize rising stars in this field. And we had a very competitive group of people who fought through, but Dr. Bayram rose to the top. And Dr. Bayram currently is an assistant professor of neurology at the University of Colorado. She has several already important positions, including chair of the International Parkinson's and Movement Disorder Society Young Members Group. Also, she's involved in, as chair of the Alzheimer's Association, Lewy Body Dementia's Professional Interest Areas Communication, and also is vice chair of the International Parkinson's and Movement Disorder Society Clinical Outcomes Training and Education Committee. Dr. Bayram is going to give a lecture today entitled Sex Differences in Lewy Body Dementia from Risk to Treatment. Before we do that, we'd like to honor you with this award. And so please come up to have this recognition. Dr. Lackland is making his way to take the picture. And so come closer, Dan. Are you good? Oh, you're ready? Ready? Okay, great. Thank you. Congratulations. Slides.
Sure.
Let's see.
That one.
This one? This one?
Yeah.
Okay, great. Let's.
All right, so thank you so much. I'm pretty excited / anxious. I don't get awards. So when I told my partner, he was like, let's make sure it's not a scam, because it just didn't feel right for him either. And my partner's not in academia, so for him, it's Nobel Prize or nothing. So it didn't make sense anyways. I'm a big Star Wars fan. I'm going to have a couple of Star Wars gifts here and there, so be prepared. I'm going to be talking to you about sex differences in Lewy body dementia today. And the research that I'm going to be talking to you about was thanks to the funding from NIA and Lewy Body Dementia Association. And of course, you know, research is not done on your own. You work with a team and you need a lot of participants to actually give you the information that you can work on. So shout out to everyone who has been down to work with me. It's been a pleasure. And also, whatever research I do, whatever paper I write, funding application I put together, my family, including my partner's family too, they have to go through it and they have to give me feedback. None of them are in academia and they're my biggest judges. So a shout out to them too, because they got to sit through the, you know, hundreds of pages to give me the feedback. So I really appreciate all their help so far. All right, so let's dive into it. So Lewy body dementia, it's an umbrella term. It's the second most common neurodegenerative dementia following Alzheimer's. And it's basically based on you presenting with a dementia that cognitive impairment's bad enough to impair your daily life activities. And they cut your brain open and you have Lewy body pathology. It includes Parkinson's disease dementia and dementia with Lewy bodies, which can be differentiated when you're alive based on when dementia started and when your motor issues, the Parkinsonism, started. But for many people, it's not as straightforward, because if you ask them, okay, when did, you know, these cognitive issues started? When did your shakiness or slowness started? They may not be able to give you an exact timeline. They may not know. They may feel like maybe it started at the same time, or maybe something came first. They're not sure. So sometimes you may not be able to make that differentiation, and you may just call them Lewy body dementia. And it's not necessarily too bad not to be able to make the differentiation, because a lot of things overlap for Parkinson's disease dementia and dementia with Lewy bodies anyways. The clinical profile overlaps, the risk factors and pathology, what you see when they pass away and you check their brains, they overlap. There are definitely differences, but overlap is pretty significant that we can get away with using the umbrella term for right now. We are not amazing at catching it. we miss a lot of people and we call them something else because the clinical profile doesn't look like what we expect. So we still use autopsy confirmation for that definite diagnosis. And, if you have 1/3 of people that you're missing during life, you really want to check their brains to make sure you're giving the right information, at least to their families after they pass away. Right now, the diagnostic criteria that we operate by are based on visual hallucinations that start early on in the dementia process, cognitive fluctuations that the attention varies from hour to hour even so significantly. At one point, they may be carrying out a normal conversation with you, and it may dip down so bad that they're just staring at a wall, not communicating at all. So people explain it very obviously for you to understand. REM sleep behavior disorder is when they act out their dreams, when their body's supposed to be paralyzed, and Parkinsonism when they have slowness, some shakiness, stiffness. They may experience issues with walking, their balance, and so on. And we typically expect to see a non-amnestic dementia where memory is relatively preserved in the beginning, and you see more executive problems, you see more visuospatial problems or attention working memory related problems. But it's not as straightforward. We miss a lot of cases, as I mentioned, and pathology can offer more than just the diagnostic confirmation. The level and presence of different pathologies actually impact the clinical profile that we see. So we're still relying on a lot of brain banks to give us a better idea about what the clinical profile is. We know that Lewy body pathology is our main villain here. And on top of that Lewy body pathology, Alzheimer's co-pathology loves tagging along too. We see it more than 50% of people with Lewy body actually have Alzheimer's co-pathology in there too. And once Alzheimer's comes into the play, it kind of likes taking the center stage, especially if you have more widespread, more burdensome Alzheimer's pathology happening in the brain, then you're going to see a more Alzheimer's-like phenotype. And that's going to make it even harder for us at the clinic because we're going to call them Alzheimer's when they actually have some Lewy body pathology ruling their dementia as well. And if you give them some of these investigational Alzheimer's drugs that are some of FDA approved, you may not be seeing any differences because perhaps Lewy body pathology was the play. So looking into the sex differences, I started off with sex, not gender, when I was doing this research, because I wanted to dive into the biology more. But, a lot of the research cohorts that we have, they use it interchangeably. And we don't really include, non-binary individuals as much. And a lot of the times you don't even ask them necessarily. Sometimes whoever's collecting the data just looks at the person and notes down something. So it's not the most reliable. But I went with sex because a lot of the databases that I was using had sex data, not gender. And I wanted to dive into that biology a bit more. So the general knowledge that I was aware of when I first started doing this research was typically females have a lower prevalence for Lewy body dementia. If you dive into the literature, it's actually not as straightforward. Even though male sex is a risk factor for Lewy body dementia, the typical knowledge we get from med school days, if you look at, for instance, Asian countries, you don't see a prominent sex difference in that prevalence. Even in the US, European countries, North American countries, the prevalence becomes similar with aging as well. So males are getting hit perhaps until around the ages of 70, 75, and then it starts becoming a bit more similar in terms of the prevalence. Females in general have a higher likelihood of getting a diagnosis later in their diseases, so they have more severe dementia by the time they get that true diagnosis, and that probably has to do with them not showing you the phenotype from the get-go. And you actually got to check the progression and see how the phenotype changes over time to be able to diagnose them. And females don't show that REM sleep behavior disorder, Parkinsonism as much, which are the core features, and it makes it easier for us to diagnosed as dementia, because Parkinsonism, you can notice it during your clinical exam. It's not really a subjective measure, it's a bit more noticeable to your eye, and you get it from the exam. REM sleep behavior disorder can be very apparent when someone's reporting, but if you have, a female later in their life and they don't have a partner, their partner passed away, because females tend to outlive their partners, then no one's going to report their sleep issues. They're not going to know they're acting out their dreams. And also, females don't act out their dreams as big as males, so their bed partners may actually not notice it either. If you cut open their brains and look at what's happening in there, we know that females have a higher likelihood of getting that Alzheimer's co-pathology tagging on to the Lewy body pathology, whereas males have a higher likelihood of having that pure Lewy body pathology. So you're seeing the phenotype that you would expect a bit more. But also, females may be having a certain type of resilience to the pathology too, because the nigral loss that we associate with Parkinsonism is not as bad for females as it is for males. Females need to reach more widespread Lewy body pathology stage for that nigral loss to hit, whereas males start that nigral loss earlier in the game, so they're getting that Parkinsonism a bit earlier in their diseases probably. But it's not just clinic separate, pathology separate. The association between the clinic and pathology seems to differ by sex as well. If you look at our main villain, Lewy body pathology, it actually doesn't cause the typical phenotype that you would expect for females. A lot of our research information comes from these big data sets that include mostly men. So the data works for them, our knowledge works for them, but actually if you look into how things are looking for females, the pathology doesn't cause as much dementia. It doesn't cause Lewy body dementia phenotype as you would expect. If you bring that Alzheimer's co-pathology into the play, it lowers your likelihood for Lewy body dementia because, the phenotype, because it looks more like Alzheimer's, yeah, but it lowers the likelihood more for males because without Alzheimer's, males, Lewy body pathology, Lewy body dementia, bring Alzheimer's into play. Okay, not showing that phenotype as much, but for females, they weren't showing the phenotype to begin with. So bringing that Alzheimer's co-pathology into play doesn't really lower their Lewy body phenotype more because they didn't even have it in the first place. But it does put them at a higher risk of experiencing dementia. So that Alzheimer's co-pathology is the more burdensome dementia pathology for the females. And the last one is the nigral loss that we expect to see in Lewy body dementia. And nigral loss, not as bad for females in the first place, but even if it does get to the stage similar to the males, it still doesn't cause Parkinsonism as much. It still doesn't associate with the Lewy body dementia phenotype as we expect as much. And all these were traditional pathology staging data. It gives you an idea, a general idea of how widespread the pathology is, but it's not necessarily a straightforward quantitative variable. So we thought, okay, neocortical pathology staging for Lewy body feels widespread, but what if females don't have as much neocortical pathology? Maybe they have 2 and males have 20, but they're still going to be in the same stage. So we looked into the regional pathology. And interestingly, we found that females actually had more regional pathology. And despite that higher levels of regional pathology burden, they didn't show the phenotype or dementia as much. So it does seem like perhaps females are showing some resilience to these pathologies before they develop the symptoms. And the differences don't, stop there. We actually see differences beyond that clinic pathology, the clinical pathological associations. We see them in the risk factors too. If you look at the genetic studies, There was a recent genetic meta-analysis, and it showed that GBA, SNCA that we typically associate with Parkinson's, Lewy body dementia risk is actually more common and effective for males. It's not as strong of a risk factor for females. And if you start doing sex stratified analyses, we looked into the X chromosome, we actually identified a risk variant just for females and not for males. But, you know, especially with these types of complex diseases, we can't really pin it to only one risk factor. We have multiple things into play, and social factors play a big role when it comes to any type of dementia. And those social factors differ by sex as well. So that, you know, typical male sex being a risk, female not having that high of a risk, you can actually change that and make females and males have similar levels of risk if you give females less education and if you discriminate them while they're receiving healthcare. But once you equalize the grounds, then yeah, the female sex resilience does come out. This is also a short, brief survey study that we did, and we're just starting to publish our data on it. So I included my grandparents because of that. They were on the flyer. They didn't have dementia. My grandma passed away a couple of years ago, but they were my first participants when I was doing my dissertation study. And I remember my grandma saying she's illiterate. She knew how to read the numbers only, and she would say, I'm probably not a good participant because, you know, what are you going to know with the knowledge you get from me? And I would tell her, you're the perfect participant because not everyone knows how to read in Turkey. You're representing a group that, you know, you're not even aware of. You're going to be their voice. You're going to be their representation in the study. So I had them on the flyer just to, you know, give a nod and remember her. And in that short survey, we found that if you actually sex stratify your analysis, you're going to hit different risk factors for females and males. For females, we find the lower subjective social status during childhood to be associated with younger onset. And this wasn't income or, you know, objective social status. This was the perceived social status that they reported, that they ranked compared to the others. And this differs from, you know, that objective measure because you can be a millionaire in a billionaire row and feel like you have a pretty low ranking. And that does put you at risk for certain things. And you can be, you know, an illiterate grandma with all your friends also literate, and you may feel like I'm pretty good ranking in my social status, and you feel good about yourself, and you may actually avoid risk for certain diseases. And we saw that for females. And for males, the more typically known factors came out, like the education, lower years of education, being from an ethnic or racial minoritized group, and also, you know, they are likely to get diagnosed at a younger age if they actually go see a PCP, general practitioner, family medicine doctor. We didn't see that difference for females, which does bring that out. You know, females are just getting that diagnosis later in the game. They're not getting caught earlier. We don't know much about the impact on daily life, but we know that majority of caregivers for this group of people, they're women. Even if you have a female with Lewy body dementia, they're actually more likely to have a woman as their care partner. So women really carry the burden of this disease. And interestingly, men are going to be the underrepresented population if you do a caregiving study. And we see that, you know, the diagnostics, the pathology, all that findings that don't include females enough, we see the effect of that in the treatment trials, and we're not getting enough females in the treatment trials to actually understand the effect of the drugs that we're testing out. There was a recent trial we did in dementia with Lewy bodies, and they had a weight limit, not a BMI limit, but a weight limit. and that caused excluding a lot of women. And I remember being the annoying one and mentioning, like, change the weight limit. This is silly. We're not checking the safety in women. And they were saying, well, because of the drug, we have to have, certain amounts by weight, so we can't go below the weight limit. Eventually, they changed it because they did realize, oh, we're not getting enough women into study after all. But, sometimes we do have to be the annoying ones to speak up. Hey, this is silly. This is not going to work. If you're checking for safety, you got to be including a lot of different people, and this is just not fair. And, like, why do we do this? It's not because I'm in love with figuring things out for women. It's not just that. But we know the community cares. We know people living with this dementia. We know their caregivers. They want treatments, but they also want to know what's happening to them. They also want to get to better diagnosis faster. And they're our primary stakeholders. Whatever research we do, whatever clinical effort we put in, is for the people at risk and living with these diseases. So we have to hear them out when they say, hey, I want better diagnostic tests. Hey, I want to know what's happening in my brain. And more importantly, you don't have to be necessarily doing this exact research to care about it and to raise awareness about it. People don't hear about research opportunities. They don't know how to find research. They don't know where to look. But they are saying, hey, if someone from an academic institution came and told me, if my doctor told me during my visit, then I'm more likely going to take part. They do trust their community partners, their community members as well, but they trust their doctors way more. And we tend to have that bias where sometimes we assume this person's not going to be interested in research. They can't travel. They don't know how to read. They don't have a care partner that can take them to the study, etc. We bring our biases, especially for this underrepresented groups in research, and we're actually the reason why they're not getting into the research in the first place. So we got to be a bit more open with, letting go of our biases whenever we talk to people, and we just gotta let them decide. And also, we gotta remember, a lot of clinical trials have so many solutions for the typical barriers that we see. So, give that information to them. Ask them if they do have a barrier, if they do have a reason not to participate, and then maybe give them the solutions and let them decide. Don't decide for them. So I'm just going to leave with very simple take to work messages. Don't take them home and leave them there. Take these to work with you. There are sex differences in Lewy body dementia. We still have a long way to go to understand exactly why, but so far, the findings are pretty strong. It's not the same disease for females and males. Pathology has more to offer us on top of just that diagnostic confirmation. But as you're probably aware too, brain banks, autopsy studies, they have a pretty, prominent bias for certain types of people. A lot of people don't know about brain donation. A lot of people don't want to go through brain donation because of certain beliefs or misconceptions. So it does fall on us to give them the right information to support them to go through such research efforts. There's still so much to do for Lewy body dementia, where this is a really small field and it's very welcoming. I've had it so easy, I can say, to advance. Everyone's been so supportive, but you don't have to be in this field to make a difference. I know I don't have to be in the stroke field to make a difference for stroke, and it's the same for this too. You may not have any interest in dementia, but you can still make a difference if you tell people about, brain donations or getting involved in research or directing them to the right resources to help them get their questions answered. So with that, I'm going to end it here, and thank you all so much.
Appreciate it. Questions in the auditorium, and Dr. Bakri, please.
What do you think is the possible pathway for that association? And do you think it's a modifiable risk? I definitely think it's a modifiable risk factor. I think both, perceived and actual social status serve as those modifiable risk factors. It may tie back to that minority stress model. If you learn you're going to be struggling through life at a very, very young age, and you go through such struggles through life, it does make changes in your brain, and it does put you at risk for many types of dementia. Alzheimer's is associated with that minority stress too. And I think that comes into play. Even if, as I mentioned, even if you're a millionaire in a billionaire row, you're feeling that discrimination. You're feeling that I'm below them. I'm not as good as them. And that impacts your brain. That definitely causes changes in the brain. But I also feel like the objective part, it probably would have come into play as well if we had a large enough sample size with more diversity to capture the wider differences for the objective measures. We just didn't have as much of a wider range for that objective measure. Subjective measure was much wider in our study.
Because that was the question I also wanted to ask as well about that, which is this, how does one address it? I guess it's better to be big fish in a small pond than to be small fish in that regard. But it's interesting. It's very similar to weathering in a way. This whole minority stress model is the same type of thing, I think. But it's fascinating that this issue of perception is also. Are there other disease entities that have also seen that type of perceived social status or ranking and earlier onset of disease or severity of disease, as far as you're aware?
Alzheimer's.
Alzheimer's is exactly like that as well. I didn't realize. I see. Yeah. Thank you. Dr. Ojala.
Thank you. This was wonderful. I kind of like tagging along with that discussion of the perceived socioeconomical status. One perhaps observation in my own sort of like lived experience in Colombia is financial independency, and particularly in women. Because in my case series with my tons of aunties, I definitely saw sort of like a pattern, and women that have financial independency or independence throughout their lives are more resilient cognitively, emotionally, and like have less comorbidities, at least sort of like an exposure. And this is kind of like my pure observation, but I think we don't often talk about that in our approaches, particularly in younger women and brain health diseases. So I think that that's probably a good variable to assess as well.
Yeah, wonderful talk. I have a different question. You obviously, with your background being from Turkey and now living in the US and doing research mainly in the US, how do you feel that culture itself influences sex differences? If you have any thoughts on that, you may not have data, but you're a very attuned person with other people, so you probably have some thoughts on that.
I think it plays a big role, and that's kind of, I think, why, Asian countries, they don't see as prominent differences. Here, Europe, North America, we see such prominent differences. A lot of the diseases would look very different in Turkey. And I remember seeing the diagnostic criteria in the textbook and looking at my patients and going like, this does not look like this disease. What the heck? But, you know, you run the test and they do have that certain type of disease, especially with things like dementia, where it's so much based on the individual's reports and also their care partner's report. How your culture reacts to certain symptoms, diseases plays a big role. I think Latin America culture is a bit similar to that too, where we hide these cognitive changes a lot. We think it's a part of regular aging, and women are less likely to report, and they do underreport the symptoms because they're supposed to, you know, keep the home alive, keep their family alive. They're the ones doing the legwork at home. So if they have a disease, they don't report it. They don't share it. They hide it more. And I do feel like that comes into play, especially in certain countries, a lot more.
Any questions online, Rael? No? Okay. Any other questions in the room? Okay. Thank you so much. Well done.